I'll be speaking about the management of corneal ulcer for general ophthalmologists, what basically they have to see and when they have to refer to a cornea specialist. So we'll be speaking little about the definition, causative organisms, investigations, management and follow-up, and especially when to refer. By definition, corneal ulcer means disruption of the epithelium with infiltration of the stroma. Most of the ulcers in India are bacterial, contributing around more than 60%. The next comes fungal, which contribute close to 30%. Remaining are parasitic and mixed infections. The two key steps in managing an ulcer, one is thorough history taking, which is often neglected, and a thorough slit lamp examination is very important in follow-up of the ulcer. Bacterial ulcers are most common. Some of them, like GPC, are sometimes even clinically we can pick them up, like they are very roundish and grayish infiltrate. And GNB is very progressive ulcer which progresses very fastly and also may have a very typical presentation. A ring infiltrate is usually seen in acanthamoeba keratitis, and a wreath shape of infiltrate is usually seen in nocardia keratitis. But sometimes the clinical guessing might be very difficult. Like this is a case of a fungal keratitis which is having a feathery margins with a dry looking ulcer. Same thing which closely mimics is a pythium keratitis, which has a totally different type of treatment which has to be given. I am just showing these just to say that sometimes even in the best of best eyes and best of best hands, it's very difficult to just clinically look at it and pinpoint the etiological agent causing the ulcer. There are 4 mandatory investigations every ulcer patient have to undergo. That is a random blood sugar to rule out any uncontrolled or diabetes, early diabetes. A syringing to know the patency of the sac, especially in GPC ulcers. Sometimes the sac is giving up the organisms, and that is the source of infection. A B-scan ultrasonography is must whenever you are not able to see the fundus to rule out any posterior segment involvement. Corneal scraping is mandatory because it will tell you whether you are going in the right direction or not. Since my other colleague is telling it in detail, I am not going into the details. The 3 questions which you have to answer when you are managing are what medications which you have to start, how to follow up, and when to refer. Usually we do a combination therapy. We start with fortified antibiotics. The preferred fortified antibiotics is fortified cefazolin with moxifloxacin or ciprofloxacin. The disadvantage is fortified antibiotics have a shorter shelf life. You have to remix and give it to the patient. Or sometimes if it's a very small infiltrate, we start with early single antibiotic. But sometimes we might miss out on coverage of all the organisms. There are 2 phases in healing of the ulcer, which is the phase 1, which is the sterilization of the cornea, where you are giving an intensive treatment where you want the organisms to be eliminated. And next is once it starts scarring and you know that the response you are getting into a healing phase, you are limiting the inflammatory response and superadded infection. As I told you before, fortified antibiotics are the treatment of choice. In cases of bacterial ulcer, the most commonly used is fortified cefazolin, which is in the dosage of 50 mg per ml. In fungus, we use usually natamycin and acanthamoeba, chlorhexidine and PHMB. 3 important adjuvant medications which we use are cycloplegics, namely atropine or homatropine. Anti-glaucoma medications are optional and especially useful when you digitally feel there is a high IOP, especially seen when there is a lot of hypopia, and oral analgesics. At presentation, it is important to pick up a severe infection. Suppose there is a 6 mm infiltrate, more thinning, and if you are seeing a perforation, you have to immediately refer the patient. If there is no perforation, you can start the patient on hourly drops day and night and then follow him up. Suppose the infection is not very severe, then just start the patient on OP basis hourly drops. Initial review should always be early. It should be around within 48 hours. And scarring is the most important clue which you will be looking out, along with the other signs of subjective improvement and also reducing the size of epithelial defect and infiltrate. In the early review, you have to look for if there is any perforation, then urgent referral as said. If there is no perforation, then you have to check for the culture. You get the sensitivity report for early sensitivity report within 48 hours and check whether you are using the sensitive drop. If you are not using the sensitive drop, then make sure that you are shifting the patient to the sensitive drop. Then if the patient is still using the sensitive drop and it's not healing, please exclude poor compliance. In 1 week review, just make sure that there is no progression, and if there is culture negative, then stop the medication and refer. If it's culture positive, again you have to check for the sensitivity, and then you have to restart the medication according to the sensitivity. In 1 week review, you have to make sure that there is there a partial or a incomplete resolution, and if at all there is poor compliance, make sure you admit the patient and keep the patient under close observation. In suppose the patient has a very slow healing, always make sure that you repeat the corneal scraping to rule out any superadded infections. Sometimes you might even have to do a corneal biopsy in cases of a deeper thing, which is better done by a cornea specialist. In fungal keratitis, we usually start with 5% netamycin, and in case of non-healing, we go for intrastromal and intracameral voriconazole, and in non-responding cases, we go for TPK. You have to always rule out for other causes of non-healing ulcers like poor compliance and associated chronic dacryocystitis, dry eye, etc. Always, in summary, I would like to say that corneal scraping is a must in case of corneal ulcer to know about the etiology. RBS syringing are mandatory in all cases. In case of bacterial, it's better to start with a combination therapy with fortified antibiotics. Close follow-up to pick up thinning and non-healing ulcer is very important, and prompt referral in case of perforation and large ulcers is very important. Thank you.
Thank you, Dr. Vijaya Lakshmi. It's not easy to summarize in 7 minutes, and it was a good. We'll revisit many of these concepts. May I request Dr. Divya to be ready with her slides, and Praful, any questions from?
In the meantime, thank you, Dr. Vijaya, for quoting my article, that survey article. And one thing, see, the general ophthalmologist always has a dilemma, what to start. Preparing concentrated drops is not an easy task. Most of them they avoid. So what is your suggestion to them if you don't have to prepare concentrated drops? What should they start with?
Sir, a broad spectrum fluoroquinolone can be started, but I would always say that preparing a fortified antibiotic is not a big task for someone who has
But
done.
he was nodding head, yes, we don't want to prepare concentrated drops.
There are issues with compounding pharmacy.
Fortified cefazolin comes in an injection of 500 mg or 1000 mg milligram. What you have to do is just take a Mellows bottle. If it's 500 mg, add those 10 ml of Mellows and then put it back in the Mellows bottle. If it's 1000 mg, put 2 bottles of Mellows into that injection. Give it in 2 bottles. That much only you have to do. You can train your assistant to do it. Any optometrist or your theatre assistant.
If you are dealing with keratitis too often, it's always to make a chart and paste it there. That will help you. If still you don't want to prepare, the ideal is whatever ma'am said. Go for high percentage fluoroquinolones. Like don't go for gatifloxacin 0.3. Go for gatifloxacin 0.5%. Or levofloxacin, which I think Santam has withdrawn from market, but that is also 1.5% is a good addition. So you can still go ahead with that. Thank you.